Dear Chairman, dear colleagues and friends, thank you very much for this very kind introduction. I'm Peter Schwarz and I'm president of the International Diabetes Federation. It's a great honor to speak here today to you, and I apologize for not being in person with you in Kuwait. I'm currently traveling in Africa to visit different African diabetes organizations. And it is very interesting that here also in Africa, where we will experience in the upcoming decade a tripling of prevalence of diabetes, we discuss intensively the use of digitalization in diabetes care. And this highlights already the topic of the next 15 minutes. I would like to discuss with you issues regarding digitalization in diabetes care, challenges to be addressed, and also how to use digitalization in diabetes care. And not only for diabetes care, also for prevention of diabetes. As you might know, prevention of diabetes, this is where my heart is beating for. My conflicts of interest, I'm cooperating with a lot of different organizations, and it's not only industry, there is also tech industry, startups, but also large NGOs and political organizations, always driven by the fact to improve the quality of diabetes care for people living with diabetes worldwide, but also including the prevention of diabetes into it. About myself, as I already have said, the last two topics are probably the most interesting one. Being president of the largest NGO in the world, the International Diabetes Federation, consisting of 250 member organizations, and being in the board in the NCD Alliance, is a combination of possibilities and opportunities really to shape the future of people living with chronic diseases, especially diabetes mellitus. But let's jump into digitalization. Why do I believe that digital tools are effective? And we are physicians, we are scientists, and we have to focus on scientific evidence. If you're looking into the science regarding changing behavior, there is a review cited here about behavior change in diabetes prevention. The bold printed aspects are important. So if you want to successfully change behavior, the strong focus should be on maintaining an intervention. The frequency and number of contacts is important. So as more contacts, as higher the outcome, and social support should be included into the intervention. So now think about, is this what we can deliver as healthcare professionals if we might have 4 minutes or 5 minutes in a quarter for our patient? No, it is not. It is the daily routine of our patients. So we have to intervene and interact with the daily routine of our patients with a high frequency, including social support. Secondly, if we are looking into behavior change, there are strategies and steps of changing behavior written down here. This is the evidence behind it: motivation, action, and maintenance. And there are techniques described like motivational interviewing, reflective listening, change talk, open questions, which you can use in the interaction with the patient. This needs time. This again needs time in the behavioral intervention for the patient. And at the end, the patient is defining when this will be happen, because again, it's the daily routine of our patients. Thirdly, if we are thinking about what is driving behavior change, and if you talk about infections and cancer, the patient normally rely and trusts us what we are recommending him. If we are talking about diabetes and obesity, we as physicians are out of the game as decider for the lifestyle of the patient or decision maker for the lifestyle of the patient. This is taken over by someone else, and this is a peer group of the patient. Again, peer group of the patient, think again about social support. This can come from this peer group. And the lifestyle of the peer group is more relevant for the lifestyle of the patient than talking to us. We might be sad about this, but this is a reality. And again, this provides an opportunity, because what is the driver for changing lifestyle? It's quality of life. Quality of life, quality of life. This is what's driving us and all our patients if we want to change something. And this happens in the daily routine of our patient. Talking about type 1 diabetes, if you think about type 1 diabetes patient who do self-management, adjusting insulin dosages and so on, how much time they spend with their disease. Over a year, it's about 6,000 hours a patient is working with his disease. We, as healthcare professionals, have 1 hour with this patient. If we do patient education, maybe a little bit more. But who is really the driver of the change of therapy? It's the daily routine of our patient, and it's the patient himself by his self-management. Finally, if we are looking into the sensor technology, here is a sensor curve shown, and it's a person where you would say, oh, it's normal A1C, but we see an up and down of glucose, a fluctuation of glucose. And today we know that this fluctuation of glucose might indicate behavioral patterns of the patient, especially in a pre-diabetic individual or pre-diabetic individual, as shown here, someone with a high degree of insulin resistance. And we might use this information by analyzing this curve and comparing to a swarm of patients, analyzing individualized and personalized daily patterns and targeting the intervention and education based on these patterns. Again, it is a daily routine for our patients. Summing this up and say, okay, can this be a background or an evidence for the use of digital tools? Yes, of course. Strongly, yes, of course. And we actually should do this. Since 2019, our guideline says we should use digital tools in diabetes care. We should use them for prevention and lifestyle modification, and we should use the data coming out of this. But again, we are scientists. Here you see gray how our drugs lower A1C, how green is lowering lifestyle, the A1C, and blue, how digital tools lower A1C, old, young, and younger digital tools. So what are younger digital tools? These are mainly smartphone-based apps. So now you might say, how can an app on a smartphone lower A1C to this content? And my answer is very straightforward. We are in the pocket of our patient. We never have been so close to our patient than being in the pocket. Every one of us is taking 1,800 decisions a day. 450 about are related to our lifestyle. Now imagine, out of the pocket from the patient, using the smartphone in the right moment, with the right educational motif, with the right motivational messaging, with the right impulse. We set impulses in the same or in this moment where the patient is taking decisions, and we only influence 10 out of the 450 lifestyle related decisions, but do this over the course of 1 year. This might be translated to 10 kilogram of weight reduction. So I'm jumping back and come back to this chart. And here you see it's young digital tools who do this behavioral intervention, lower A1C. And what we actually see here is the lifestyle lowering of A1C, because these digital tools influence our lifestyle change. So modern diabetology, I think, could look like this, and we should not fear this. But there is a big challenge, and this is artificial intelligence. And some of us fear AI because we see, we don't know what to do with this. Some of us are totally excited by the use of AI. We are very sure that AI will be disruptive in the way how we do diabetology and how we do interventions for our patients. And we had the chance with the European Diabetes Forum to put all this together. And first is, if 10 people talk about AI, you have probably 15 different positions. What is AI? And there are different levels. There is AI, there's machine learning, there's deep machine learning. And we are on the edge of transforming the use of AI in clinical care because of this deep machine learning. In the past, AI was trained by us or was trained by what we have given the computer to train AI. Today, AI has already stepped into an autonomous learning. So it's a kind of generative AI that AI uses all the sources they can get to learn, to get trained. And this is a new quality. It's a quantum jump of the use of AI, because suddenly AI can use everything. But suddenly AI can also use wrong sources. So going deeper into it, if we look into the evidence, there are a lot of evidence-driven applications in diabetes care. And there is a lot of opportunities for the AI in using it to shape interventions in diabetes care, personalizing medicine, collating data, predicting events, doing prevention, preventing complications. So everything what we actually want to do in diabetes care can be supported or can be pushed by the use of AI. And we can actually improve the way of how we deliver interoperable diabetes care by the use of AI. And many of the gaps we see in diabetes care can be closed by AI. I will not say that AI will solve all our problems, but AI has the opportunity to leverage the quality of diabetes care to a totally different not foreseen level currently. But there are also downsides of the use of AI. And I mentioned already that AI today learns from everything. I discussed this with colleagues from Google, and they actually mentioned that they know that 85% of the clinical and medical content in the internet is wrong. So now imagine AI learns from everything AI has access to, and it's also learning from the wrong content because AI doesn't know what is wrong and what is right. And now AI generates himself with wrong content, then might be we might experience a danger by the use of AI. So this is a clear aspect where I would say we should be open to use AI, but we should be the driver. We should be the frontiers in training AI. And the European Diabetes Forum has made very clear recommendation using AI should be on the last mile and on the edge in targeting the patient, providing self-management support, for providing education for the patient. So facilitating patient-centered care by use of AI, empowering us to use AI, involving us in training AI, but we also need a robust regulation. And this is the asset of the European Union, that we have a good regulation. We often suffer the regulation and shout about the regulation, but we have a good and robust regulation, which is an advantage if you are talking about the use of AI. AI can be and should be used to develop new data standards and aggregate data available from our patient. And we should develop clinical studies to show the evidence and the effect of AI in diabetes care. And I think this means we should use AI or see AI as any other new way of delivering healthcare, and we should qualify and assess AI in the same manner. And if you are now looking into the reality today, this is an example from Germany where digital tools in diabetes care are already licensed due to the robust regulation we have in Germany and the European Union. And there are examples like this is an app called Vitadio, and they are using diabetes education programs to support type 2 diabetes patients in monitoring them, providing education, internalizing knowledge, so helping the patient to build up new routines and then establishing these routines. And they use AI, it's called Alfred, where the patient is making photos of the food. This is analyzed, not to blame the patient now, but to use the information to help the patient to provide or to develop a better next meal or to support him to have a more healthy next meal. Secondly, it's Mebix. This is another digital health application in Germany, and it's actually more advanced in the use of AI. You make a photo again from the food, and it doesn't matter what kind of food it is. It can be local food, it can be international food, and it's qualifying and quantifying the food. So you actually get the amounts of food in it. And again, this is used to help the patient to provide or to develop a better next meal. Another application, it's called Una Health, and this is using the glucose sensor and is using the shape of the glucose curve to help the patient to educate the patient about nutritional patterns. And One2Diga, it's a Swedish application, is using the sensor and is monitoring the shape of the curve and immediately comparing this to a swarm of more than 1,000 other patients using the same sensor on the same app, and comparing the daily patterns and making very clear recommendations based on 6 areas of diabetes care to the patient. So, for example, today, 6:35, you inject 22 units of long-acting insulin. So very precise. This, in my eyes, is diabetology out of the pocket of the patient. And they use neural network and deep machine learning technology to compare the patient to a swarm of other patients and make, based on the shape of the glucose curve, recommendations what to do. Now you might say, no, we don't want to have this, yeah, because we are the diabetologists. We want to do this to our patient. But think about Rwanda. There are 360,000 patients living with diabetes and one diabetologist, but a digital infrastructure which is better than in Europe. So there are opportunities of this modern technology, especially also in low and very low income countries. And this provides a big opportunity because in low and very low income countries, there is the biggest increase in prevalence of diabetes, and there are the biggest number of people living with diabetes there. To give you one example, outside Europe, this is India, this is Mathu, this is an AI-based agent, and this agent was developed by a network of more than 300 physicians in India. They trained this agent, and you can use this agent actually today also in Kuwait. You can use it in your language and talk to Madhu and ask, for example, Madhu to interpret your glucose curve, or ask Madhu about everything what is related to your diabetes. In many cases, Madhu is referring to the physician, but in many cases, it helps immediately the patient to get educated and to get empowered to take actions on his diabetes. So it's worth to try. And there are many, many different agents like Madhu coming up in the upcoming weeks and months, we have to say, in the moment. So the battle will be, which brain is better? Is it our brain or is it the brain of artificial intelligence? I think artificial intelligence will win, but the father and the mother of AI should be the brain of the physician. So we should train AI in the way that it provides safe and better diabetes care to our patient. At the end, let's be a little bit more disruptive at the end and talking about digital biomarkers. There are tons of biomarkers stored and measured on the smartphone we have. And if I would ask you who is the best to measure diabetes or to diagnose diabetes, we might say it's A1C, it's OGTT, or it's fasting glucose. It is not. It's the online shopping behavior. There are good studies showing that based on your online shopping behavior, you might identify the rise of hyperglycemia 3 months ahead of the start of hyperglycemia. So this might be even 10 years or 15 years before we diagnose diabetes in a clinical care. So again, we could say, no, we don't want to use this data because we are physicians. We measure glucose. Why not? Why should we not use digital biomarkers if we would be able to identify our patients earlier? So I think we should think about this. And there are tons of digital biomarkers. If we are able to qualify these biomarkers for diabetes diagnosis, this would be, I think, a very cool approach. So think about using wearables and smartphones and any kind of biomarker you can measure, collect this data, visualize this data back to the patient. This is something where every one of us would be agree. Then we could use to prevent diabetes. We provide an intervention, as I presented earlier, to help the patient to change lifestyle to prevent diabetes. Also, everyone would be agree. If you talk about diabetes prevention, yeah, we are very close to education and diabetes education. So this is a little step. Then someone might say, no, we are a bit reserved because we do the diabetes education. But why not? Why not providing bringing the education to the smartphone of the patient, especially in underserved served communities? And if you do education, why not doing diabetes care? For example, like the example this 1,2-DIGA I presented you. I think we should be open, but we should be the frontier and the driver for this field. And to keep it in our hands, what AI is doing. But modern diabetology could look like in the future like this. At the end, I'm the president of the International Diabetes Federation, and serving IDF for me means serving and focusing on improving the quality of diabetes care for people living with diabetes worldwide. This means for me addressing the need of people living with diabetes. And this need might vary, but addressing the need, I think this would be our ultimate goal we should fulfill. And knowing the need of the patient would be the first step. Again, here, digitalization could help to assess this need or individualized need of people living with diabetes. Why the International Diabetes Federation? Because I think we need a powerful voice for the life or for the need or for the challenges in diabetes care. So a powerful voice for people living with diabetes. And we need this global community of people who are passionate to improve quality of diabetes care. I truly believe that everyone in the world has a right to have the same accessibility and availability of diabetes care. And we are not very good in this yet. There are millions of people living with diabetes have no accessibility and no availability of diabetes, and they die because of no accessibility of diabetes care. And this is what we have to change. And I have three goals. First, being in the brain of every politician in the world, being in the pocket of every diabetes patient, and being the heart of every healthcare professional. How do we want to achieve this? Firstly, we will develop a global diabetes index. And once a year, we will measure at 100,000 patients, 100 healthcare professionals, the quality of diabetes care, translate this into an index to 100, and it tells you exactly where you stand in the quality of diabetes care in your environment. And we will feed this, or we will release this data for free 1 month ahead of World Diabetes Day, and then feed this back to the politicians. So now imagine the politician in your country sees, oh, our quality of diabetes care is good, but our neighbor is still a bit better. Maybe then the Minister of Health says, oh, we have to change something. Maybe he is ignoring. But now think about after 1 year, we do it again. And now the Minister of Health sees, oh, our neighbor has even improved. And then maybe people ask, why have you not done already something last year? So we want to build a momentum to motivate stakeholders to invest in quality of diabetes care. Secondly, pocket of every diabetes patient. I explained it. I think there is a brilliant opportunity to reach people, to encourage people, to empower people, to help them to perform better self-management. And this is an opportunity on a global scale. Diabetes education has no different language. This is one language, and the smartphone can be the hub to deliver this to our patient. Finally, being in the heart of every healthcare professional is a fellowship program IDF has released. And this fellowship program has just started. And fellows of you are invited to become fellow of the International Diabetes Federation. Building this community of healthcare professionals who are passionate in improving the quality of diabetes care. So join the fellowship of the International Diabetes Federation in building this community. And I think this will make an impact to the life of people living with diabetes. If you have your smartphone in the hand, you might scan this QR code, and this is a WhatsApp channel where I want to witness or I want to show the activities the International Diabetes Federation is doing, and I am doing to improve quality of diabetes care. So, for example, being in the moment in Africa and visiting member organizations in Africa. And you are warmly invited to join, and I will deliver all the information regarding the fellowship program by this channel. I also invite you to come to Bangkok to our global big World Diabetes Congress. This will be the place where we can discuss all these topics, including digitalization and AI. There are many faces of people living with diabetes. Let's work together to put a smile on these faces of people living with diabetes because they deserve a better life. Join the social media channels and follow the International Diabetes Federation. But most importantly, let's work together with all our ideas, all our passion to finally help our patients and the communities to walk away from diabetes. Thank you very much for your attention. Thank you very much for your passion. Thank you very much for your actions.